after, so I guess we should probably go ahead and get started. Good morning, everyone. This is Terry Kearns, the chair of the response subcommittee for the SURG. And first of all, thank to everyone for your patience in having to reschedule this meeting to today's date. Appreciate it. At this point, we want to start the meeting and establish, do our roll call to establish quorum. So I'll pass that to you, Crystal.
Thank you. And just a note for members and members of the public, please do not use the chat to communicate anything other than technical difficulties that you might be having. Anything in the chat does become part of the public record. We would also ask that you refrain from text messaging members on the side or anything like that as well. Anything you would add, Joel? Okay. So with that, I will take roll. Christine Payson.
Present.
Dr. Stephanie Woodard. Dr. Terry Kearns.
Present.
Shayla Holmes.
Present.
Gina Flores O'Toole. With that, Chair, we have a quorum with 3 of our 5 members present.
Great, thank you so much for that. We'll move on to the next item, which is public comment. So Crystal, again, can you see if there is anyone available for public comment? We would just say that public comment will be received via Zoom by raising your hand or unmuting yourself. And when we go through and ask for public comment, which is now, public comment will be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, in discussion of those comments. No actions may be taken upon a matter raised during a period devoted to comments by the general public unless the matter itself has been specifically included as an agenda item upon which action may be taken pursuant to NRS 241.020.
Crystal Duarte, for the record, please raise your hand using the Zoom function or come off of mute. And we can, the chair will acknowledge you if you would like to make public comment. I don't see anyone indicating they'd like to make public comment.
Okay, and I would just note that we will have another public comment period at the end of the meeting. So let's move on to the next agenda item, which is to review and approve the October 27, 2022 response subcommittee meeting minutes. Those were all loaded into the website and provided prior to the meeting. So I open it up at this time. If anyone has any recommendations they'd like to make for changes to the minutes. Doesn't appear there's any comment. If anyone would like to move to approve the minutes.
This is Shayla Holmes for the record. I'll move to approve the minutes.
Thank you, Shayla, for that motion. Anyone second that motion?
Terry, this is Christine. I just want to note that I will abstain because I was not present at that meeting.
Okay, so Joel, then if we only have 2 members to vote, do we have to push this for approval till our next meeting?
No, as long as the 2 members, no, that's fine. Because just to approve the minutes, as long as you have, I believe it's a majority of the members who are present at the meeting, you should be fine.
Okay, I think we only have 2 that were present on the call and we need 3, so.
I thought that there was 3 with 1 abstaining, not 2 with 1 abstaining.
No, Crystal, is that correct? 2 or 3 members, 1 abstaining.
So then those two members can vote, and if they approve it, then you're good to go.
Okay, so then I would second that motion to approve the October 27, 2022 response subcommittee meeting minutes. All in favor, say aye.
Aye.
Any opposed? And any abstentions?
Just me, Christine Payson, abstention.
Okay. So then we have approval for those meeting minutes. And we'll move on to the next agenda item. So at this point, we just want to kind of, because it has been since October, since we've last met as the response subcommittee, like to review the guidance moving forward for our 2023 subcommittee. And first of all is that as the SURG response subcommittee members, we're asking that each member submit recommendations that hopefully you can present on whenever possible. And if you are not able to present on those, if you have a tangible recommendation, if you have someone else that you can suggest as a subject matter expert who can provide the specific targeted presentation related to that recommendation. And we're requesting that the presentations be 5 minutes, and then for each recommendation, and then allow time for questions and answers following the presentation. And I would note that there is a template that we have developed that would be provided to the subject matter experts or the presenters to present on any recommendations. Additionally, we are not including recommendations that have already been reported out in our 2022 SURG report. However, if there was a previous recommendation that still was listed as needing further research, that can be resubmitted along with additional research for the subcommittee to consider. And then rather than using an iterative weighting process in this 2023 subcommittee, we're encouraged to present, discuss, and then refine the recommendations in our spring and summer meetings, and then weight those recommendations for inclusion in the fall for the report. And the full SURG meeting dedicated to harm reduction took place on April 5th. And for those that attended, there were some recommendations that were made in that meeting as well. Moving on to the next slide. Oh, sorry. Okay. So that's our guidance. That's where we're at currently with our process. And then Crystal, are you going to go over the survey feedback?
Yeah, I can do that. This is Crystal Duarte for the record. You might remember getting a survey. I know there's a lot of them, but this would have happened at the end of last year about what worked well. So we had 5 responses that the subcommittees worked well. People felt like they were able to cover more ground and move things along. The prioritization process worked well, and the discussion of recommendations were positive. SCI coordination and staff organization was mentioned by 4 people, and shared documents to compile information were also mentioned as being helpful. And then what could be improved? More presentations on contested recommendations, better definition of subcommittees, or a full SURG meeting dedicated to crossover recommendations. Clarification on the recommendation ranking process, more predictable schedule of meetings. I think we have worked on that where possible. The length of meetings shortened to 90 minutes or less. Addressing harm reduction in its own separate capacity. We did do that on April 5th. And asking SURG members what they would like to learn from this specific presentation. More presentations from providers instead of from the state, and better adherence to public comment period time limits. Those were the things that we noted in this, that were noted in the survey as areas for improvement. Because we are starting a new year, we wanted to ask members if there's any additional feedback that you would like to note about the recommendations process or the subcommittee meetings process, so that we can take that into consideration, because we will be meeting Again, in May, we have a meeting, and then I think our next one isn't until July or August. So we do have a regularly set schedule. We did take that information and make a change. And we need to keep moving forward and improve these meetings for you in a way that is beneficial. So if you have additional feedback, we can take that now.
For the record, this is Sherry Kearns. I would just like to add that in addition to those recommendations that we had made in the 2022 report, one of the things that we do want to do is follow those recommendations. So as part of the meeting supporting documents, you did receive a tracking sheet that's tracking specific recommendations that go along with track legislation that goes along with our recommendations. So it's not like those recommendations were just put out there and we're not going to look at them again because there may be changes or amendments that are put in with that, or we may need to make new recommendations if those don't go through to the legislation. So I just did want to add that. Are there any other comments? I don't see any hands raised, so we'll go ahead and move on. And I apologize if you guys hear my dogs barking. They like to be recognized during our meetings. So, but we want to review AB 374, that section 10, that has requirements specific to the response subcommittee and to recommendations in our 2022 annual report.
Chair Kearns, I wanted to note for the record that member Gina Flores O'Toole is entering our meeting now.
Oh, great. Welcome. Glad to have you on the call. So as part of AB 374, first of all, we're looking at the 10 cross-cutting elements. So these went across either all 3 of our subcommittees or at least 2 and more. So with the response, the prevention, and then the treatment and recovery. And the first is B, the access evidence-based strategies for preventing substance use and intervening to stop substance use. And then there are the 4 components under that. C is to assess and evaluate existing pathways to treatment and recovery for persons with substance use disorder, including without limitation, such persons who are members of special populations. Then moving on, H under AB 374 was examine qualitative and quantitative data to understand the risk factors that contribute to substance use and the rates of substance use and substance use disorder, again, focusing on special populations. Q is to study, evaluate, and make recommendations to the Department of Health and Human Services concerning the use of money described in section 10.5 of this act to address substance use disorder, and with those 5 areas of the funding that are included as part of the legislation that are listed below. And then we move on to specific recommendations for the response subcommittee. And the first is D, which is to work and understand how residents of the state who are involved in criminal justice system access support for treatment and recovery from substance use disorder. I, which was to develop strategies for local, state, and federal law enforcement and public health agencies to respond to and prevent overdoses and plan for implementing those strategies. K was recommend strategies to improve coordination between local, state, and federal law enforcement and public health agencies to enhance the communication of timely and relevant information related to substance use and reduce duplicative data collection and research. Then we go to L, which is to evaluate current systems for sharing information between agencies, and that was specifically regarding trafficking and the distribution of legal and illegal substances associated with substance use disorder, which include but not limited to heroin and other synthetic and non-synthetic opiates and stimulants, to study the effects of substance use and on the criminal justice system, including without limitation law enforcement agencies and correctional institutions, and that was M on AB 374. And then N is to study the sources and manufacturers of substances which are associated with substance use disorders, including without limitation heroin, other synthetic and non-synthetic opiates and stimulants, and methods and resources for preventing the manufacture, trafficking, and sale of such substances. Then we go to O, which is to study the effectiveness of criminal and civil penalties at presenting the misuse of substances and substance use disorders, and the manufacture, trafficking, and sale of substances which are associated with substance use disorder, again, including without limitation heroin and other synthetic and non-synthetic opiates and stimulants. And then P, evaluate the effects of substance use disorder on the economy of our state. So at this point, we're going to look at the recommendations and which part they then align to with our recommendations. So under D, that work to understand how residents of the state are involved in the criminal justice system access supports for treatment and of recovery from substance use disorder. We had the recommendation to implement follow-ups and referrals and linkage of care for justice involved individuals. That was including individuals leaving the justice system and pregnant or birthing persons with opioid use disorder. And that came out of the treatment and recovery subcommittee, is number 3. And then I, the developing strategies for local, state, and federal law enforcement and public health agencies to respond to and prevent overdoses, and plans for implementing those strategies. Response subcommittee number 1 recommendation was support legislation to establish a statewide and regional overdose fatality review committee and recommend an allocation of funding to support the ORF to effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies in accordance with established best practices such as the Bureau of Justice Assistance Overdose Fatality Review, a practitioner's guide to implementation. Next, we had K, which was to recommend strategies to improve coordination between local, state, and federal law enforcement and public health agencies for the enhancement of communication of timely and relevant information related to substance use and reduce that duplicative data collection and research. Our recommendation on that originated out of the prevention subcommittee was supported by a backbone agency that specializes in data collection, evaluation, analysis, and assessment, and provides consultation to entities across Nevada to help improve the internal local data collection systems and create a comprehensive statewide data sharing system that includes all state dashboards and public data. And I would note on these recommendations out of the response subcommittee were aligned, and some of these were then worded and put together with the other ones, and that was why this went to the prevention subcommittee. Moving on, we have L, which was to evaluate current systems for information sharing between agencies regarding the trafficking, distribution of legal and illegal substances associated with substance use disorder. And this was again to support a backbone agency that specializes in that data collection, evaluation, analysis, and assessment, and provides the consultation to entities across Nevada. So the same as previously, which was prevention recommendation number 2. Moving on to M, study the effectiveness of substance use disorders on the criminal justice system, including without limitation law enforcement agencies and correctional institutions. And this was where we had moved on for further review. And it was really to resolve that conflict between the Good Samaritan Drug Overdose Act and the drug-induced homicide law. And immediate actions may include recommending community level education using best practice guidelines as well as education for law enforcement personnel. Next is N, study the sources and manufacture of substances which are associated with substance use disorder, again, with those specific items named, but not limited to those. And there were no recommendations put forth to directly address this specific element. Then we move on to O, which is that study the effectiveness of criminal and civil penalties at preventing the misuse of substances and substance use disorder and the manufacture, trafficking, and sale of substances which are associated with substance use disorder. And this was to revise the penalties based on the quantity of fentanyl, analogs, or other synthetic drugs of high potency that are trafficked, which was our response subcommittee number 2 recommendation. Then we move to Q, is study, evaluate, and make recommendations to the Department of Health and Human Services concerning the use of money described in section 10.5. And our recommendations from our subcommittee on that were to leverage existing programs and funding to develop these outreach response providers and or personnel that can respond to any suspected overdose and offer follow-up support, referrals, and services to individual and loved ones following an overdose. The providers and or personnel to be deployed to anyone being released from institutional and community settings, hospitals, carceral facilities, and other institutional settings who are being discharged post-overdose or suspected overdose. And then that was our response recommendation number 3. The response recommendation number 4 was to fund personnel and resources for an independent medical examiners for investigations and report to specify the cause of death in overdose cases. And then I believe this is our last one, is P, evaluate the effects of substance use disorders on the economy of our state. And there we had no recommendations put forth that directly address this element. At this point, I think we're ready to move on to our legislative session update, which Vice Chair Holmes will provide for you.
Okay, the 2023 legislative session update. We had a handout, as Dr. Kearns mentioned earlier on, that was sent out with the backup documentation that has a list of everything that is essentially related to substance use disorder in our current legislative body. Some of these you'll see are tied to those recommendations that Dr. Kearns just went over. And I don't think, so that document was as of April 5th and April 15th was dead day. So some of these bills have died. So the ones that I know have died, I'll try to point out as we're going through. So our Senate bills for the 2023 session that overlap with the recommendations are the first one being SB 4. That one is still active, and it revises provisions governing certain programs to pay for prescription drugs, pharmaceutical services, and other benefits. This ties to recommendation number 5 and number 13. We have SB 35, which is still alive and active, which establishes the crimes of low-level trafficking in fentanyl, mid-level trafficking in fentanyl, and high-level trafficking in fentanyl. We have SB 197, which has died, and that prohibits unauthorized sale or possession of fentanyl or carfentanil and increases penalties for violation. So that one is no longer applicable for tracking. SB 412 increases penalty for possession of fentanyl and other substances. And that one's currently got a waiver. It hasn't, it was heard on 417, I believe, in the judiciary and ended up with a no jurisdiction comment, but it has not died yet. Next slide, please. On the assembly side of things, AB 132 creates the committee to review overdose fatalities. That's recommendation number 10. AB 156 ensures the availability of medication-assisted treatment in jails, detention centers, and correctional facilities for people diagnosed with opioid use disorder and continuation of treatment on release or transfer. This ties to recommendations number 5, 11, and 12. Next slide, please. And so that's the ones that correlate with our recommendation. If you want to see the full list, go to that handout. And at this point in time, is there any other legislation that's not on that handout that you guys would like to discuss or identify that we should be tracking at this point in time?
This is Terry Kearns for the record. I would just add to what you said is that, as Shayla mentioned, the updates from the legislation aren't updated to the date, but more like a monthly update. So if you want to get more specifics on the currents, you can go into Nellis on the state legislative site and follow those bills. So I would add that. I don't have any additional that I want to follow. I don't know if any other members have anything they would like followed as well.
Okay, I'm not seeing anyone. Crystal, are you seeing anyone? I don't see any hands up or anything. We will move on to agenda item number 7, overview of recommendations received and next steps. So we received 2 recommendations, both relating to the resolving the conflict between the Good Samaritan law and the drug-induced homicide law. This first one was submitted by Dr. Kearns. With the justification that the Good Samaritan Act SB 459 states that a person acting in good faith would not be arrested for drug-related charges if they call 911, provides support to the person who overdosed and stayed with them. However, according to the drug-induced homicide law, which makes it a Class A felony if the death of a person is approximately caused by a controlled substance which was sold, given, traded, or otherwise made available to him or her by another person in violation of this chapter, the person who sold, gave, or traded, or otherwise made the substance available to him or her is guilty of murder. Therefore, people are afraid to call 911 for those who have overdosed out of fear of prosecution under NRS 453.333. There was previous presentations that we had, so you can go back and see the presentations done on May 9th and May 9th, 2022, and August 23rd, 2022. And some potential possible presenters in the future. Christine Payson had, I believe, was the May 9th presentation, or the August 23rd presentation. I can't quite recall, but Christine had spoke on this topic previously, as well as Lisa Lee and Dr. Carla Wagner. So we do have that recommendation up for discussion. Dr. Kearns, is there anything else you would want to add to that, or?
Yes, what I would add to this is I think this continues to be an issue, because I know I listened in on the Senate Judiciary hearing on SB 35, and that's the whole weighting of the fentanyl and different charges for the different levels. And there was testimony by members of the public that people continue to be afraid to call because they still feel like they don't feel comfortable with law enforcement and that they will get arrested. So that continues to be a theme, not specific to this one, but that was specifically talked about in that one. And then also that, there's charges that are already there. So, why are we even looking to change some of this legislation and make it almost more restrictive? So that's not 100% applicable, but I do know that the Good Sam Act and people being in fear of calling because being afraid that they're going to get arrested, it continues to be an issue in our communities. And I would ask as well, Christine Payson, if you have any other comments on this as well.
Christine Payson for the record. I personally don't feel like there's a conflict. The Good Sam law isn't a free pass, and it shouldn't be a free pass. It states pretty clearly what they won't be arrested for, and what you still can be arrested for, even if you're calling for medical help on an overdose. If you shoot someone and then call paramedics, you're still responsible for shooting them. It's not a free pass, and I don't think that the Good Sam law should be changed to be a free pass on the more serious drug offenses.
Thank you. I appreciate those comments. If there's no other conversation regarding recommendation 1, we can move on to recommendation 2, which I submitted with some research. That link there is a document that's got an overview of all 50 states' Good Samaritan laws in there. And so what I took, so revise NRS 453C.150 to include language similar to the state of Delaware. So the state of Delaware's language reads, defendant made a good faith effort. If a defendant made a good faith effort to promptly seek, provide, or obtain emergency medical or law enforcement assistance to another person who is experiencing a medical emergency after using a Schedule 1 or 2 controlled substance and whose death would otherwise form the basis of criminal liability. So they provide coverage with that clause. Or Rhode Island has the language, an eligible person will not be charged or prosecuted for the offense of controlled substance delivery resulting in death if a person in good faith made without malice and in the absence of evidence of an intent to defraud sought medical assistance for someone experiencing a controlled substance overdose, and the evidence for the charge was gained because of seeking the medical assistance. The protection only applies to the death of an adult and does not apply to the offense of controlled substance transaction resulting in death of a minor. So those states, Delaware and Rhode Island, and also Vermont, which I didn't include, are the states that currently do not prosecute for drug-induced homicide or drug delivery resulting in death in relation to the Good Samaritan laws. I know Lisa Lee had presented on this previously, which is why I had listed her as a possible presenter. I'm not sure if there's perhaps a contact I can find in any of those states to present or share outcomes or impacts of those laws, but I suppose that's an option that I can attempt to find somebody who'd be willing to do that as well, to bring in a third party to talk about the pros and the cons of how they've gotten there. But open for discussion, recommendation number 2 from anybody on the committee.
This is Terry Kearns for the record. I don't have a specific recommendation for this, but what I would say is I think both of these recommendations get at trying to meld that line of public safety and public health, and walking that and trying to really cover both parts, because this issue I feel is both a public safety and public health issue. So those are just my comments for the record.
Thank you, Dr. Kearns. I can't help but agree that we definitely want to have that. We want folks to feel comfortable calling 911 when somebody is dying. But I hear Christine Payson loud and clear that we also want to hold those accountable who are actively participating in killing someone. So hopefully we can find something that works for the state of Nevada and meets both of those needs. With that, our next meeting is scheduled for May 15th at 9 a.m. And we are seeking any recommendations at this point in time for presentations at that meeting. It's coming up here pretty quick, so we need to confirm folks that would be potential presenters.
This is Terry Kearns for the record. I do have a recommendation on a possible recommendation to discuss in workshop. And basically, I know this was previously brought up by Dr. Dixon in the treatment and recovery subcommittee, but also is an issue that's cross-cutting across that subcommittee and also prevention and harm reduction. And this recommendation really has to do with the bridge programs in the emergency departments. And while that may not seem like it has a 100% fit in the response subcommittee, I think there's a component to that, because I think there's a couple of components. The bridge program, as I understand it, as Dr. Dixon talked about, was for the induction of buprenorphine within the emergency departments. But there's also been a lot of work done about having naloxone available without a prescription in the emergency departments that people can get, because we did have testimony within our, I don't remember if it was the larger SURG or the subcommittees, that basically giving someone a prescription for naloxone when they're in the emergency department and have experienced an overdose and are leaving, that a large majority of those prescriptions are not getting filled. So to have the ability to give someone actual naloxone as opposed to a prescription would work a lot better in trying to prevent future overdoses, and having people having the tools in their hands to be able to reverse an overdose should they need to. One of the things I know that Jessica Johnson, who is a SURG committee member and also the SURG prevention subcommittee chair, has been working with California, because they've implemented this program in all of their emergency departments in California, and kind of have a template of steps to go through. So my suggestion would be that we reach out to Jessica Johnson and she can direct us to who those presenters are that may be able to discuss this more in depth, and then also to kind of refine what we mean by a bridge program, whether that's both the bup induction and the naloxone, being able to give people naloxone. I think the majority of the members are aware that the FDA recently made naloxone an over-the-counter medication, so it doesn't require a prescription. But again, going to a pharmacy or going somewhere and getting it, especially if you're dealing with populations that can't afford to buy it, that's one thing. So being able to provide it free of charge to people within our emergency departments that have suffered an overdose when they are discharged without that prescription. That's a lot of words, and I know I said a lot, but just to kind of give the scope of this recommendation. Again, I'm not sure this would be one specifically for the response subcommittee as opposed to a cross-cutting one, but I just want to put that out to the members, and we can talk about that, or if anyone has any thoughts.
I think that's a fabulous idea. I think the idea of anybody being able to have naloxone in their hands after experiencing an overdose is important. I think there's room to expand that perhaps as well, to where naloxone can be given to any family members or friends that are present with them in the hospital on discharge. We were having this conversation the other day during a naloxone training with my staff within my department of giving our individuals who utilize substances naloxone is fabulous because of the circles they run in. But if they're overdosing, they're most likely not the one utilizing the naloxone on themselves. It's going to be a friend or a family or somebody around them having to administer it. So as many people that have those individuals within their circles having it is, I think, critical. I think this is a way to do that. Along the same lines, what we've been trying to figure out, at least within my county, is, and I never want to add more to our emergency medical staff, but perhaps our paramedics having naloxone on board that could be left with individuals at the scene when they're leaving with somebody overdosing is another thing that we've been trying to figure out, and what does that look like. But the more naloxone in the community, the better, I think. So I think this is a great program.
Terry Kearns, for the record, I agree with everything that you said, Shayla. And in terms of EMS providing leave behind or law enforcement providing leave behind, I know that some of the work that CASAT has been doing with their naloxone distribution and the naloxone saturation plan under the state opioid response grant does look at leave behind programs. And from my understanding, there are some communities that are already doing that through EMS or through law enforcement. So perhaps we could get Morgan Green from CASAT to present to us on what's currently being done in the state. And I think that Morgan also has a piece, if the bridge program was implemented in our state, I think CASAT would probably be at the forefront of how to get that out to hospitals and how to implement it as well. So Morgan Green would have input into that as well.
Wonderful. Is there any other comments or conversation that the committee would like to have regarding recommendations or future suggestions?
This is Terry Kearns again for the record. And this is a very draft and rudimentary comment, but I know I saw a presentation from a gentleman out of parole and probation up in Washoe County who started a program. It's called the START program, and it's working with individuals that are in the criminal justice system, primarily in the specialty courts. And some program, this START program that they, or STAR, I'm sorry, I believe it's STAR, that they've implemented to try to assist people with that reentry and with a lot of the issues that they're dealing with. I don't have the full scope, but I can reach out. I don't remember the gentleman's name, but I can provide that at a later time.
All right. Sometimes silence brings out thoughts, so just giving it a moment to see if anybody has anything else they'd like to add or suggest. All right, I think if we are closing out this agenda item.
It's a question, and again, Christine, I'm sorry to put you on the spot on this, but I know you are doing a lot of work on these overdose response teams. Is there anything that we can do as this committee, because that falls, I think, squarely in the response to help move that along? I know you're looking at it in Clark County. I don't know if there's anything bigger statewide for that program.
At this point, we're just trying to address it in the Clark County area. And then if we get that one rolling, then we can use that as a template and hopefully expand it to other parts of the state. What exactly that'll look like, I don't know yet either. But that was why I put the recommendation that at least some of the funding be used to hire a coordinator that would work with the responding law enforcement personnel that can do the warm handoff, and then that coordinator can help get the linkage to care for the victims and their family.
So is it safe to say that at this point it's too soon, not ready for public, or is that something that we could potentially get a presentation on, do you think?
I suppose we could get a presentation on what we want it to look like. It wouldn't be ready by the May meeting, at least not from me, because I know that I'm not available for the first 15 days of May, so I wouldn't be able to get anything together.
Okay. Well, we'll keep you in mind for future presentations then. It sounds like there's room for hope there. With that, I think we do just want to remind everyone, I think Dr. Kearns reminded us at the beginning, but I suppose a follow-up that recommendations can be made at any point in time utilizing that survey. So if lightning strikes for any of those areas that we've talked about today in regards to our assignments and those subsections, that they can be added at any point in time for discussion at future meetings. And with that, I think we're ready for agenda item number 8.
Which agenda item number 8 takes us to public comment. And if anyone has any public comment at this point, and all of the items that we discussed earlier are still that 3-minute time limit. Crystal, do you see anyone? I see a hand raised.
I do see a hand raised from Trey. And just a reminder, there's a 3-minute time limit for public comment.
Thank you. My name is Trey Lapp. I'm the director of Group 6 Partners. I wanted to talk specifically about efforts to improve Good Samaritan law. So this law passed in 2015. The biggest challenge I think we have is education of the judiciary and lawyers and cops. The 40 states that have Good Samaritan laws, 31 of those states have not even addressed them in any sort of legal capacity. There was a case that almost went to before a judge in Washoe County, but the hang up here is public education, accessing the law, invoking the law. So while it's valuable to change the letter of the law, it doesn't matter if the law isn't put into action. And so I would certainly want to just make a comment that when thinking about improving utilization of the intent of the Good Samaritan law passed in 2015, that we include a public education component that's critical. In 2018, through a Boyd and Pat Coalition, we did a CLE, continuing legal education, 1-hour training on the law. Even in the creation of that training, it was difficult to find an attorney who would use the statutory definition to actually use the Good Samaritan law in a case. So couple of things that courts have ruled on is that the person wasn't high enough, they didn't have genuine intent. So these are some of the details, and of course, police ignoring the whole thing. So I think it's valuable to address that, accessing Nevada sheriffs and chiefs, DA association, prosecutors, to see where they are on the law, I think would be very helpful in informing what would be the best approach to that. Thank you for the opportunity.
Thank you for those comments. Do we have anyone else? I don't see any hand raised, but Crystal, do you see any, or anyone calling in?
I don't see any hands raised. All of our participants do have a camera showing, so I don't see anybody just joined by phone. And again, if you were to come off of mute, that would be an indication you wanted to speak, or if you started your camera, or raise your hand. So we have a few options if you wanted to take additional public comment. And I don't see anybody taking any of those actions.
Okay, at this point, we can move on to the next agenda item which is the adjournment. I would just add to all the committee members, if you do, as Shayla, Vice Chair Holmes commented, if you do have a moment of clarity and something comes to your mind that you would like to provide a recommendation, please do so through that survey tool. And as Crystal already commented, our next meeting is scheduled for May 15th. So look forward to some materials on that, or if you have recommendations, please get those in prior to that. At this point, we'll adjourn the meeting.
Thank you.
All right, thank you very much.